So today we are going to talk about rating open clinical notes, so an educational tool for supervision. So being able to get those supervision CEs for those live today. Because if we do any kind of special CEs, whether that's supervision or ethics, we have to give the Ohio board a little bit more information. And now I'm about to round. So we do have a session objective for participants to be able to identify several considerations, strategies for writing open notes, and explain how you could use those as a documentation, use those clinical documentation tools as an educational tool in supervision. When I use the term trainee or new health professional, new clinician, that really means kind of the wide, broad array of that. So new clinicians, residents, interns, students, new supervisees that are new to practice. So the wide variety of terms. It was hard to stick with one particular consistent term, particularly when referencing literature, because some of the articles I referenced were about residency, some of them were not specifically about residency. And some of this kind of goes back to a previous presentation back in April 2021, when we covered some of the 21st Century Cures Act practice updates, including the provision regarding open notes and ensuring that patients have ease of access to their clinical record. So I think that was April 30th of 2021 that we did talk a little bit about that. And it's interesting because when I first started my first counseling job outside of grad school, the standard practice at that organization was to write your notes, they were all paper notes at the time, but to write your notes in session and review the note with your client, obtaining their signature before they left and scheduled for their next session. So I've started out being very open to writing open notes. So when we think about clinical documentation, we have to consider multiple audiences, and there are multiple audiences. And clinical documentation really started initially, and the electronic push to clinical documentation was initially prompted by insurance and billing procedures. So to be able to bill and get reimbursed for your services. You also have yourself, remind yourself of what's gone on and the course of treatment over time, and future providers, because people may switch, physicians, counselors, go on to another provider in the future, and you want that next person to be able to pick up where you left off and have a good understanding of where the treatment history has been. For your colleagues, your clinical documentation facilitates coordination care across the whole healthcare team and allows for really just that better collaboration. Which obviously if you can do in person is great, but that clinical documentation in the electronic or paper record, whatever kind of record should facilitate coordination. Patients, and when I say patients, I also actually mean parents and families. So parents, if it's a child or adolescent patient, family in the broad array of scope. So that might be it could be a parent, it could be a spouse, it could be somebody's child, but very often the clinical audiences become those family members as well, and the medical legal system. So clinical documentation, if there is some kind of legal situation, the clinical documentation becomes a legal document in those scenarios. So open notes. Why use open notes? They can help promote self-management and motivate behavior change, even with patients who have limited English proficiency, because that's one thing that people worry about as well. If there's a health literacy or an actual English literacy issue, will this worsen disparities? And it actually shows that it doesn't. It can help promote that self-management and behavior change in all patients. It promotes transparency in documentation, which can open the door for new conversations, which can enhance health literacy and improve the relationship with your patients. Open notes provide an opportunity to enhance patient safety, engagement, and satisfaction because they might have a better understanding of their care. And specifically when looking at mental health settings, open notes have been noted to have a positive effect, including reducing stigma, enhancing the therapeutic alliance, and empowering patients to be active in their care. So when it comes to supervision, clinical documentation can be an important educational tool. It supports the trainee's synthesis of information and provides an opportunity for the supervisor to assess and give feedback to the supervisee. Supervisees, new trainees, they need guidance on efficient clinical documentation because we want them to show not only medical necessity, which is required, They need to be clinically relevant notes, things that can be, information that's useful to the team and understood by patients. We also want supervisees to be thoughtful and sensitive to culture, age, gender, sexual orientation, disability status. Most trainees are just getting instruction on SOAP notes, and that really is not going to be broad enough. It gives you the basic requirements, but it doesn't really help you understand that nuance. And some trainees do get some instruction on particularly the electronic pieces, kind of more on the fly, or they learn by observing others, but they can really benefit from structured guidance around this. So in one of the studies I referenced, they noted 3 areas for clinical supervisors and medical educators to consider when looking at clinical documentation. So the need for increased feedback and mentorship on writing notes, the influence of role modeling on how the supervisee or trainee is perceiving open notes and their approach to writing clinical documentation, and the opportunity to help learners prepare for a future of transparency in clinical practice. So just really getting them used to open, transparent clinical documentation from the beginning. So when we look at how well trainees write notes in general, there was a chart review conducted of some psychiatry residents' notes by 4 board certified psychiatrists, 1 being certified in child and adolescent psychiatry, and then 2 non-psychiatrists. So they used a medical student and an experienced psychiatric recreation therapist. They did a chart review to look at how ready the notes were for a patient to read them, meaning that the reviewers read the note and were not concerned that the patient would be offended if they read the note. And in that broad scope, 70% of the notes were ready. There was no concern noted by the people who reviewed them. And they were reviewed by a psychiatrist and non-psychiatrist each. Now, if you allowed room for some concern where maybe they weren't perfectly ready, the client might be a little confused or offended, but if we presume that that's okay and it's an opportunity to open discussion, then 93% of the notes were ready. Interestingly, concerns were more often brought up by the psychiatrists than non-psychiatrists, but non-psychiatrists actually identified far more potentially sensitive topics and jargon. They just, for whatever reason, deemed them to be less concerning. And something to consider with clinicians and early in training is that the earlier you are in clinical practice, there's kind of you feel kind of compelled to overly document it. And this is something that I would work with a lot of my folks with, is they would document themselves right out of billing. Just writing too much. You don't have to write out your entire thought process in detail. You don't have to write the entire rationale. And you really have to have this nuance, because not only can you write yourself out of billing, but at the end of the day, if there's an audit, insurance is looking at these, you might be writing way too much stuff that is far too personal and that isn't necessary for that medical necessity piece. Trainees and new clinicians actually want feedback on their notes. So when residents are surveyed, they report that in general, they receive little faculty feedback on their clinical notes, and those that are getting some feedback rate that feedback pretty poorly. The vast majority of them are interested in receiving feedback and formal education on writing clinical notes. And most of them believe that it would actually improve communication and overall care. So common concerns that have been noted throughout the literature from not only supervisees, trainees, but also folks in clinical, more seasoned in clinical practice. So the concern being, maybe I'll be less candid, or I'll want to be less candid in my note writing. And that about 76% of residents in a survey noted that they thought they would be less candid. But there's lots of value in being candid, even if that's required, even in full transparency. It just requires us being a little bit more thoughtful. There's a concern it might overwhelm patients. So 73% thought it could overwhelm patients, particularly when there's a health literacy issue. But again, this is an opportunity to improve health literacy and engage patients actively in their care. There was a concern about this might increase my workload. Maybe I'll have to take additional time answering questions, maybe about my notes or my colleagues' notes. But when looked at it, the surveys actually indicate this doesn't really increase workload substantially. Although maybe at the beginning, some report taking a little bit more time with the notes at first, because you're kind of retraining your brain to write notes differently. Concern that patients might find non-trivial errors. So about almost 40% of residents thought that that would be a concern, and that those errors could be used in malpractice lawsuits, or maybe the patient would even get mad and take a screenshot and post it on social media. That seems a little outlandish, but it's possible that people, they're certainly concerned about stuff like that. And beyond errors, kind of their patients might find misalignments. So misalignments defined in the literature is mismatches between the patient and clinician on symptoms, events, or the significance of symptoms or events. And open notes really invites patients to identify misalignments, which can improve overall care. So there could be disagreement, but there's a good reason to have a discussion around it. And it might mean that we have to explain the clinical importance or relevance of particular things that we keep in the record. But it really is an opportunity to engage that conversation. So some tips for ourselves and for trainees on writing open notes. Keep notes simple. Include only what's necessary, what you have to have for billing and treatment. Remove the extraneous information. You don't need all of the details. Try to avoid copying and pasting and templates when moving forward over time. Note templates and copying forward can lead to misalignments. They can lead to errors. Waiting to document can also lead to misalignments and errors. You might remember something differently or think about the plan differently in a way that wasn't discussed with the patient. And if you do go in and note that, it might be important to put something like, after discussion with my supervisor or colleagues, ... If you're concerned that a patient might read a diagnosis or a symptom description and they might either be offended or confused, discuss it before you document it so that there's no surprises if they decide to go in and look at those notes later. So use real descriptive neutral language. The use of objective, jargon-free, non-judgmental language can humanize notes. We have to pay attention to tone and terminology, but we also don't want to sugarcoat things and be less than truthful. It's great if you're able to include strengths, accomplishments, progress, because patients don't want to read their notes and necessarily just see all bad things, nor should you only be putting all bad things in there. That doesn't show the care team, what other progress is being made with patients, making sure to include those and avoid pejorative terms. So things like unkempt, disheveled. And actually that is one positive with open notes is that when looked at over time, people do tend to write less judgmental in a less judgmental way, knowing that patients might actually read that. Avoid using abbreviations and acronyms. When reviewing charts for frequently used abbreviations, researchers actually found be quite a bit of inconsistent and incorrect use of terms and the use of a lot of things that have multiple meanings. So that could be very confusing for everybody, including your care team, not just the patient. Really being aware of tone and language throughout all of this. A couple more tips. When it comes to open notes, encourage your trainee to talk with their patients about reviewing their notes. According to the organization opennotes.org, the simple act of inviting patients to review notes can help establish a safe environment and really safe space for discussing things. Be prepared to answer questions that they might have, ask them for feedback, make it a conversation. If patients find a mistake, encourage them to let you know and be willing to correct errors if they are in fact an error. And if it's not an error, but it's a misalignment, then your trainee or you might have to explain why something has to be kept in there. If a patient has a real concern and really disagrees with something that you feel is important to be kept in the chart clinically, or your supervisee feels like it's not important to be kept in the chart, then maybe even agree to document their disagreement and how they feel about it, just so that there is a note that the patient doesn't agree with the full thing. But there's ways to keep this a conversation. So if using notes in supervision as an educational tool, review and discuss a couple notes each week during supervision. Obviously, over time, you're going to want to do that less. You won't need to do it as often, but make it just kind of part of standard supervision practice that we're going to do this. If you do find problems, don't just change it. That's, I think, for ease of time and just everybody's sanity, that seems like the easier thing. We'll all just correct the notes so that way it's not a problem, but that doesn't allow for that educational piece. So send it back to them, review during supervision, use this as an opportunity. It's also an opportunity to explore any kind of bias that the supervisee might be bringing to their note writing and their documentation. It could open a conversation about how they're feeling with that particular patient or what's going on, with the clinical picture of that patient. And it's really a chance for supervisees to learn more and improve their skills. Discuss how to document highly sensitive content. Depending on what the system each organization has, there might be ways of keeping a note closed or almost always closed. But keep in mind, patients, even if they have to go through the long, tedious process, they've always had full access to their entire record. But if there's highly sensitive information and maybe you're concerned, your supervisee's concerned that a patient could come to harm because they might be in maybe domestic violence situation, and what if the spouse, who's the abuser, happens to read the note while the patient's reading the note? Could the patient be harmed? There might be ways of marking information as more highly sensitive or highly confidential. And also maybe you just don't need to document everything. So keeping those things into consideration. And another really important consideration is that the supervisor or faculty attitudes towards open notes and towards clinical documentation is certainly going to influence how your trainee, supervisee, resident approaches all of those things. So approaching that from a kind of a positive standpoint is definitely going to help everybody. So a couple of fun slides and examples taken straight from the articles on improving your notes. So in the column that you see, so this would be the original version of the note. Collateral information highlights Mrs. C's denial of symptoms. Any thoughts, and please feel free to unmute because I can't necessarily see who's doing what. Any thoughts on how that could be better written?
Could say Ms. C disagreed with these specific symptoms.
Sure. The example that they gave in that article was after obtaining collateral information, appears Ms. C is minimizing severity of symptoms. But yeah, disagreed would work. Discuss my recommendation for inpatient detox with Mr. W, however, he refused. Any takers? I want to keep putting Russell on the spot, so I'll go forward. I discussed my recommendation, weighing risks and benefits. He declined. We'll continue exploring alternative options. So the real problem with the ones on the left being, that very negative language. So looking denial, refusal, it definitely paints a certain picture. Miss G expressed paranoid delusions that people are out to get them. So use caution. Not all quotes are going to be taken fully correctly, and they're not all necessary. So a better way would be Mr. G reports that people are treating him unfairly, which leads to anxiety and fear. Because frankly, that's the problem anyway. It's the anxiety and fear. That's what we really need to hone in on. Ms. P reports worsening mood and has been non-compliant with medication. Sure, any of you who are familiar with me at all know my first complaint about the way that is written. Ms. P reports worsening mood, that he's missed most doses of medications, noted difficulty accessing new medication due to financial constraints. And then here's a little scenario. So Miss C is a woman in her 30s, you've seen for a year for depression, now reveals that she was molested by an uncle several times when she was 9. She was never revealed this to anyone and was overwhelmed with feelings when she mentioned it. She asked you not to put it in the medical record. So can you think of a way that you could write this so that you can honor that, but still achieve what you need to? I'll let you chew on it. So functioning well, it's telepram, sleeping, eating well. Today she mentioned some incidents in her past that we've not discussed before that were very significant for her. We'll explore the incidents further next time. Because you don't need those details. Those details aren't important to anybody, except the patient. And so those are my references. I'm happy to take questions, thoughts. Oh, where's